Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Welcome to Behind the Operative Room, a series of podcasts in which we talk about the fascinating world of cardiac surgery. I am Bleri CELMETA, a minimally invasive cardiac surgeon working in Galeazzi-Sant'Ambrogio Hospital in Milan, Italy, and I am thrilled to have you join me today. In the previous episode, we talked about the first open-heart surgeries performed by two pioneers in the surgical field. Dr. John Lewis, which performed the first successful open-heart surgery in moderate hypothermia, and Dr. John Gibbon, the inventor of the first heart-lung machine, which made possible the first open-heart surgery in history. After more than 20 years of countless experiments and despite the obvious skepticism in the academic and surgical community, in February 1952, Dr. Gibbon performed the first ever cardiac operation in cardiopulmonary bypass on a human being. The patient was a 15-month-old baby with severe heart failure symptoms from what was believed to be an atrial septal defect. Unfortunately, the diagnosis was incorrect and the atrial septum was found to be intact intraoperatively. The autopsy confirmed a patent ductus arteriosus instead. The second patient, an 18-year-old girl with a confirmed atrial septal defect diagnosis, underwent surgery some months later in May 1953. She survived the operation uneventfully, setting the milestone of the first successful cardiac surgery operation on a heart-lung machine. It was as an invisible wall had finally fallen, laying the foundation for the subsequent impressive development of the cardiac surgery. However, after the first promising result, the next four patients operated by Gibbon did not survive after the operation. He was so deeply discouraged that decided to never operate another patient with the auxiliary of the heart-lung machine and to suspend any further research on the subject on his institution. But other scientists and fellow heart surgeons pursued the efforts by trying to fulfill his vision. In 1954, Clarence Crawford in Stockholm, Sweden, performed the second successful open-heart surgery with a heart-lungs machine, while in 1955, Clarence Dennis in New York, United States, performed the third one. The narrative of the birth of traditional cardiac surgery would not be complete without speaking about one of its founding fathers, Clarence Walton Lillehei. He was the inventor of the so-called controlled cross-circulation, of the DeWalt-Lillehei bubble oxygenator, which was defined by Denton Cooley as the key that opened the door of the cardiac surgery, the inventor of the first portable pacemaker and of many valvular prostheses like the St. Jude valve. He was also the first surgeon who operated congenital complex cardiac diseases like tetralogy of Fallot and atrioventricular canal. Returning to the beginning of this fantastic journey, the hypothermic arrest had been used for the surgical correction of simple pathologies, but could not be used for complex cardiac surgery procedures. On the other hand, the first experiences with Gibbon's heart-lung machine demonstrated the many critical issues that had yet to be resolved. In this context, Lillehei designed a completely different way to address the problem. Instead of using a mechanical heart-lung machine, he thought of replacing it with the heart and lungs of a living, bigger-sized donor. According to this scheme, all the venous deoxygenated blood of the child patient was drained to the venous system of the donor parent. From here, the blood was oxygenated by the lungs of the parent and pumped from his heart to the arterial system of the little child patient through tubes, bypassing completely the patient's heart. This would allow to open his heart and surgically correct the anomaly. The first patient operated by this technique was an infant diagnosed with an interventricular septal defect. In March 1954, with the patient's father as a donor, Lillehei surgically closed the interventricular defect by direct suturing with the help of the cross-circulation technique. Unfortunately, the little patient died some days later due to infectious complications of the respiratory tract. However, this paved the way for other and more complex cardiac operations using the cross-circulation. In the following year, Lillehei would operate 45 little patients, of which 28 would leave the hospital completely healed, patients which only 1 year before would have certainly died. Now, in the following decades, the cross-circulation invented by Lillehei would be less and less used. In fact, nowadays, nobody would think of it as a solution of cardiac surgery. This happened mostly by merit of the continuous work of perfection of the heart-lung machine, above all from John Kirklin in Mayo Clinic and Denton Cooley in Houston, but also by merit of Lillehei himself, which, with the invention of the Walton Lillehei bubble oxygenator, finally put the cardiac surgery on the reach of every patient who needed it. The last decades of the 20th century saw an extension of cardiac surgery centers worldwide, which together performed hundreds of thousands of operations on the heart. The next important step in the evolution of cardiac surgery was the implementation of the minimally invasive access. Even though the first reported operations on the heart were performed in an extended thoracotomy, in the following years and during the consolidation of the surgical experience, the traditional cardiac surgery implemented always a full median sternotomy. This vision began to change in the early 90s, when the growing interest on laparoscopy in general surgery reflected the need for less invasive solutions, even in the field of cardiac surgery. In the mid-90s, almost contemporary, Cosgrove and Kohn independently described the first minimally invasive cardiac surgeries through a parasternal approach and through mini-sternotomy. The first one was subsequently abandoned because of the need for ribs dislodgement with consequent mechanical respiratory complications and difficulty of conversion to full sternotomy. In 1996, for the first time in history, a video-assisted cardiac surgery through a mini-thoracotomy was performed by Carpentier to repair a mitral valve. With the improvement of the technology of the endoscopes, a better vision of the surgical field was made possible through smaller and smaller incisions. Moreover, the cannulas became smaller and improved their performance in terms of hemodynamics. The single lung ventilation became always more popular, while carbon dioxide flooding of the operative field improved the airing in conditions of limited direct access to the heart. Nowadays, in many hospitals around the world, minimally invasive cardiac surgery has become the gold standard for the treatment of valvular pathologies. Many studies have shown that while maintaining the same safety when compared to the traditional approach, minimally invasive cardiac surgery may reduce the ventilation duration and total hospital stay, the need for postoperative transfusion and postoperative pain, favoring a faster recovery and return to the everyday life. On the other hand, though, concerns of a steeper learning curve, longer cardiopulmonary bypass time and cross-clamp time, and higher risk of vascular complications associated with peripheric cannulation have been raised. Finally, the next cornerstone of cardiac surgery evolution was the robotic use for surgical purposes. It was always Carpentier who first performed a totally robotic mitral valve repair with the help of the Da Vinci surgical system. Since then, robotic cardiac surgery has gained some popularity, mostly in the United States and especially for coronary revascularization surgery, but this type of surgery has not gained, however, a widespread use, mostly due to the steep learning curve, the adequately trained staff, and increased medical costs. In conclusion, heart surgery has come a long way since the first experiences in the late 19th century. We can say without a doubt that the transformation of a so-called forbidden surgery to a routinely performed operation is one of the most important achievements of the past century in the medical field. This wouldn't have been possible without the work, dedication, and vision of hundreds of surgeons and scientists, which transformed what seemed impossible to a life-saving operation for many patients. With today's armamentarium of the modern surgeon, from traditional heart surgery to the off-pump surgery, from the minimally invasive access to the totally robotic approach, and with the percutaneous solution for the most fragile patients, we can offer a patient-tailored solution that better addresses their cardiac pathology. Thank you for being with me today, and stay tuned for more episodes.